So now this morning, we get to have a really exciting talk from one of our own fourth-year residents, Naomi Roselaar. And she comes to us by way of not that far away, growing up in Appleton, Wisconsin. Did her undergraduate degree at Yale in molecular, cellular, and developmental biology. Went to New York to Stony Brook for her medical school. And then how lucky are we that she matched here for her residency. And she has impressed so many people throughout her residency within and outside of our department, always getting nice words about her. She's also the only resident I know to be able to match into a urogynecology fellowship without ever even doing a urogynecology rotation. So that was impressive. But yes, we're also so excited that next year she will be joining the University Hospitals Case Western in Cleveland for her urogynecology fellowship, where she'll be trained by a really wonderful and well-respected group of urogynecologists. So can't wait to hear your talk. Go ahead.
Thank you, everyone, for those really nice introductions and extremely applicable note about fidgeting and little snack exercises from Dr. Bachbach. And thank you for coming to my grand rounds this morning. Today, we're going to talk about exercise and surgery inside and outside the operating room. This is a topic that I chose because it's something that I currently enjoy. And I think it's very applicable to what I want to have as a surgeon with hopefully a somewhat more balanced life than I do in residency. I'm lucky to be very physically able, and exercise has always been something that I enjoy. I grew up doing ballet, and I love group exercise, as many of the residents and attendings here can attest if they've done yoga or solid core or played tennis with me on a nice day. And I also noticed that during residency, we do a lot of physical activity. You can look at any of the interns' step counts on their phones and see that. But I noticed that we were crouching in a lot of awkward positions or standing in the same position for long periods of time, which isn't necessarily the same as other types of exercise or moving around. And most notably in residency, there is very little time to do the kinds of exercise that I used to do previously. Even before residency, I combined my interest in medicine and exercise in other ways. One of my first experiences with surgery at all was as a clinical research assistant in sports medicine, where exercise was very integral to the patient care and recovery. And the attendings that I worked with were holding workout classes before clinic and group runs in the parks on weekends. I did not attend those events, but I did go to a boot camp run by a former Rockette whose hip was coincidentally fixed by one of the attendings. As a resident at the start of a surgical career, hopefully a long one, this topic is a way to bring my interest in surgery and exercise together and hopefully set myself up and as well for success. Additionally, this is a fairly new topic. A lot of the research is from the past 15 or 20 years, but there has recently been renewed interest in exercise and surgery related topics at various conferences. For example, at SGS this year, there were 6 separate presentations or posters on this topic. I have no financial disclosures. There are a lot of studies that show how exercise benefits patients before, during, and after surgery. And like many things in medicine, recommendations for patients can be easily ignored by the people taking care of them. It is also hard to study surgeons as we are not great patients or subjects ourselves. But in this talk, I'd like to focus on how exercise and stretches inside and outside the operating room play a role in surgeons' physical wellness, performance, and longevity. To do this, today we will review the physical demands of surgery, outline exercise-related intraoperative interventions for surgeons, demonstrate examples of intraoperative exercises and stretches, and examine the effects of exercising outside the operating rooms. We'll also discuss the utility of some of these things for OBGYNs. Surgery is a very physical profession. Throughout training and practice, surgeons perform a lot of repetitive motions, they incur injury, and they accumulate disability burden in the form of time off, practice restrictions and modifications, and in some cases, even take early retirement. Although gynecologic surgeons do a wide variety of procedures, all of these things can be seen in open surgery, laparoscopic surgery, robotic surgery, and vaginal surgery. When looking at the prevalence of common degenerative musculoskeletal conditions, studies across surgical specialties show high rates of degenerative spine disease, rotator cuff injuries, and carpal tunnel syndrome. Interestingly and relevant to those of us at an academic institution, a survey of 530 vaginal surgeons from the American Urogynecologic Society and the International Urogynecologic Association found that teaching is associated with increased self-reported musculoskeletal disorders. The study also observed that left-handedness and length of time in practice were protective against musculoskeletal discomfort. I am right-handed, unfortunately. The residency is a very active time. It's not necessarily associated with physical fitness. One interesting study showed that interns in orthopedic surgery lost overall body mass, lean tissue mass, and body fat throughout their intern year. And if this is happening to the surgeons that are the most likely to have squat racks in their call rooms, it's also probably true for those devices. Surgeons also experience chronic pain. A meta-analysis from 2018 estimated the 12-month prevalence of work-related musculoskeletal pain of the neck, shoulder, back, and upper extremities. They looked at 21 studies with a total of 5,800 surgeons and interventionalists, the majority of whom were in general surgery, gynecology, and urology. For these surgeons, the 12-month prevalence of neck pain was 65%, shoulder pain was 52%, upper back pain was 59%, and upper extremity pain was 39%. This data was gathered using the Nordic Musculoskeletal Questionnaire, NMQ, which has been validated in many populations, including various types of labor. In comparison to chronic pain in surgeons, a study of unionized apprentice United States construction workers using the NMQ found the 12-month prevalence of those same types of pain to be 32% for neck pain, 28% for shoulder pain, 4% for pain, and 42% for extremity pain. All that is to say is that surgery is a very physical occupation. Physical activity in general, though, has clearly been shown to be beneficial. Increased physical activity is associated with decreased premature mortality and reduced risk of dozens of chronic diseases. Though the studies are small and mostly preliminary, I'd like to review what the data shows on exercise-related interventions for surgeons. Many of the interventions are those that surgeons can incorporate in real time in the operating room. Proposed interventions to reduce injury and pain and to promote surgeon longevity include adhering to principles of ergonomics and implementing ergonomic education programs, utilizing interoperative stretching and exercises, and taking micro breaks during surgery. It sounds a lot like the exercise snacks that Dr. Bhagavat brought up earlier. We'll talk about each of these individually and how they can be combined as well for surgeon benefit. Ergonomics is the science of people's efficiency in their working environment, and it's also often described as fitting a job or an environment to a person. The purpose is to optimize well-being and efficiency. Basic surgical ergonomics involves appropriate positioning of the surgeon's body and of the surgical environment, including monitors, tables, steps, surgical instruments, and everything else in the room. Adjustments should be made depending on the type of surgery being performed. In open surgery, the recommendation is to have your table height at about elbow level. And we'll use table height as an example of showing how things need to be modified, even when it's the same surgeon doing different surgery. For laparoscopic surgery, the best elbow angle is 90 to 110 degrees. So the table height for laparoscopic surgery should be lower than that for open surgery. And even within the same surgery, modifications should be made. For example, during laparoscopic surgery, table height should be adjusted based on the instrument grip for the type of instrument that you're using. Something with a pistol grip instrument, like a ligature or something that opens in that fashion, mean the wrist has less ulnar deviation than an inline instrument, like a needle driver or something in a straight line. And so when switching to an inline instrument, making the bed height lower can offset some of that wrist strain. Anesthesiologists probably won't like this part of the talk. In robotic surgery, the armrest should be adjusted to keep the hands near elbow level as well. And it's important to frequently adjust the clutch tool to continue to utilize this posture throughout the surgery. Because general surgeons publish a fair amount of the ergonomics literature, there's less guidance and data on ergonomics in vaginal surgery. The overall recommendations include maintaining a neutral and upright posture and minimizing awkward postures as you are able to. We all know that there are lots of awkward postures, and many of the studies discuss that as well. When surgeons of varying heights operate together, the ergonomic recommendation is to make the bed height fit the tallest surgeon and provide steps for everyone else. Ergonomic principles also recommend using things like armrests and seats when able, although I couldn't find any good examples of those besides a stool in the operating room. Recommendations like this seem really integral to robotic surgery, so I expected robotic surgeries to be associated with less pain and improved posture. And while a survey of surgeons showed that robotic surgeons had the fewest complaints overall about physical discomfort and musculoskeletal disorders, there were still many issues present. Multiple studies show that the arm and shoulder pain is improved for robotic surgeons compared with laparoscopic surgery, but neck stiffness and back stiffness are very prevalent. While seemingly simple, ergonomics is often overlooked. The Society of Surgical Ergonomics found that the most commonly reported barriers to ergonomic implementation are lack of education, surgical institutional culture, and forgetting. The American College of Surgeons published a comprehensive surgical ergonomics recommendations guidebook in 2025, and it is available online for free for reference, and it is also structured in a way that it can be posted in operating rooms to be printed out. In addition to some detailed diagrams and instructions, one of my favorite recommendations from the guidebook is to designate an ergonomics buddy who can give reminders of surgical ergonomic interventions. And you might even have one sitting next to you. In addition to optimizing ergonomics, there are multiple exercises and stretching regimens that have been developed to be done while scrubbed in the operating room or unscrubbed in between cases. These are two examples of neck and back exercises from that same surgical ergonomics recommendations guidebook. And these can be done while scrubbed or not. This one has a sort of grayed out area of the arm because that's a modification you can do if you're outside the operating room and not scrubbed. If you are scrubbed, they wouldn't recommend that. One possible method for implementation of these exercises is through educational modules or presentations. A study of surgical residents in Miami showed that self-reported decreased neck and back pain occurred after 3 modules that were taught by physical therapists. And these modules focused on learning and practicing these intraoperative exercises. Studies have yet to be done on whether incorporating this learning into surgical training will have any long-term effects or affect those surgeons' longevity. In most of the studies I came across, implementation of ergonomic education and perioperative exercise education came from physical therapists and physical therapy teams. While I do think it's a good idea and very helpful for a study situation, the exercises are typically straightforward and can be learned and completed without professional guidance like a PT. And needing a PT is likely a barrier to implementing this as well. So certainly something that you can read while you're scrubbing in the OR and implement yourself or learn about and then take on. Micro breaks are defined as pauses during surgery to complete these stretches or exercises. They occur more than once an hour, typically every 20 to 40 minutes, and can last a few minutes at a time. Some of the studies even looked at micro breaks of only 20 seconds. The micro breaks were originally shown to reduce strain and pain for data entry professionals, and studies on micro breaks in the operating room show benefits for surgeons as well. A small experimental study from 2013 showed that micro breaks can prevent muscle fatigue during surgery. 16 surgeons were tested for muscle fatigue by holding up a 2.5 kilogram weight with an outstretched arm for as long as possible. Each surgeon was tested 3 times, once before any surgery, once after a surgery where micro breaks were performed, and once after a surgery without micro breaks. In this study, the micro breaks were only 20 seconds long and occurred every 20 minutes. The muscle fatigue that was seen after surgery without micro breaks was significantly increased compared with the control test prior to any surgery. But the muscle fatigue seen after surgery with microbreaks was unchanged from the control. The same study assessed surgeon precision through a validated test of tracing a star-shaped track with medicine-bound scissors. Errors were noted as any contact with the borders of the track, and errors were noted to be 7 times higher than baseline after surgery without breaks compared with the control. Errors were only twice as high after the surgery with the microbreaks, and that was not statistically significant. These tests were obviously experiments in small groups in a controlled setting and cannot be extrapolated to surgical outcomes, but they do speak to the effects of breaks on mitigating fatigue and its sequelae, and that is one of the underlying principles of this entire process. Another interesting early study assessed surgeon stress via cortisol levels and alpha amylase in surgeon saliva pre and post-operatively, and found that surgeons that took a break every 25 minutes had a 22% lower cortisol levels intraoperatively. This study also looked at a few other measures of surgeon stress and found that there were many lower levels of stress in those surgeons that took breaks. It suggests that the breaks reduce stress in some way, which again can't be directly correlated with surgical outcomes, but probably helpful in the day-to-day surgeon. Interestingly, in this study, they took breaks for 5 minutes, and every time they took a break, they actually desufflated the patient as well, as all of these surgeries were complex laparoscopic cases for a variety of surgeons that took more than 2 hours. I was also very impressed by the protocol that involved using a straw to discreetly sample the surgeon's saliva, and the fact that they deemed this low intrusion to the surgery. When talking about breaks and pauses and interruptions in surgery, one of the biggest concerns is the impact of these breaks on surgical duration. In a study of 56 surgeons across a variety of specialties, breaks of 60 to 90 seconds every 20 minutes did not significantly increase the risk or increase the duration of the surgery. And in that same study where they took 5-minute breaks every 25 minutes, the average total time for these very complex laparoscopic surgeries was only 4 minutes longer total in the surgeries where they took breaks. This was not seen to be significant. One example of micro breaks or intraoperative stretches during these times is the Mayo Clinic developed web-based app called OR Stretch. It features a timer to remind surgeons to take breaks, and it has 70-second guided stretches to utilize during breaks while the surgeons are still scrubbed. You can have this circulator also hit the start stretching now button at any time while you're in the surgery, and then you can take a spontaneous micro break. There are standing exercises and also seated exercises depending on what type of surgery is being performed, and they have done some studies showing the benefits. Since we've all been sitting here, you all been sitting here for a fair amount of time, I think it's a good time to take a break. So let's try some. Since you guys are in a seated position at this time, you can follow along with the seated exercise.
This video is to guide you through a series of movements which have been selected to specifically address areas of your muscles, joints, and nerves. Throughout all activities, it's important for you to breathe freely, allowing air to flow in and out without restriction. Keep all motions gentle and smooth, without bouncing or adding additional force such as using the other hand to increase movement. You will likely feel some tension as you approach the end of your available movement. This should feel like tension, not pain. Your available movement will likely be different than other people around you. Everyone is different, and you should avoid attempting to move beyond the sensation of tension. If one of the activities causes pain, stop and move on to the next one. The base position for these activities is sitting balanced on the front part of your chair, with your feet approximately shoulder width apart, sitting as tall as you can. Your hands are at the level of your belly button, with your fingers interlaced. Take a deep breath in, filling out your ribs. Keep your chest high as you breathe out. Shrug your shoulders up toward your ears, then back, pinching your shoulder blades together. Then lower them down, keeping your chest up. Bring your arms up to shoulder height with your palms facing your chest. Reach your hands forward as far as you can and follow them with your shoulders to reach further. Pinch your shoulder blades together as you return your hands to your chest. Turn your hands over with your palms facing away from your body and repeat the forward reach, following with your shoulders. Pinch your shoulder blades together as you return your hands to your chest. Return to the base position. Lift your face toward the ceiling and let your head drop back. Take a deep breath in, feeling the lengthening on the front of your neck and upper chest. Relax as you release your breath and return to the forward-facing base position. Tuck your chin to your chest, feeling lengthening in the back of your neck. Continue curling forward, feeling the lengthening down your thoracic spine. Relax and return to the forward-facing base position. Without moving your left foot, hook your right foot behind your left leg, somewhere comfortable between the heel and the calf. This will help you keep your pelvis locked, facing forward. Turn your head so you are looking over your right shoulder, feeling the lengthening in the back of your neck. Continue rotating with your shoulders, feeling the lengthening down your spine. Return to facing forward and place your feet back in the base position. Side bend to the left, leading with your shoulder and curling your trunk to the left. Feel the lengthening along the right side of your torso. Return to the base position. Without moving your right foot, hook your left foot behind your right leg, somewhere comfortable between the heel and the calf. Keep your pelvis locked, facing forward. Turn your head so you are looking over your left shoulder, feeling the lengthening in the back of your neck. Continue rotating with your shoulders, feeling the lengthening down your spine. Return to facing forward and place your feet back in the base position. Side bend to the right, leading with your shoulder and curling your trunk to the right. Feel the lengthening along the left side of your torso. Return to the base position. Take a deep breath as you lift your chest up toward the ceiling and gently arch your low back. You should not be leaning backwards as you arch your back. Relax as you breathe out, returning to the base position. Perform an abdominal crunch around your hands. You should not be leaning forward as you perform the crunch. Return to the base position. And finish, take a deep breath in and out.
That was the example where they talked you through a little bit more, but the example in the app tends to be less wordy and does only take 70 seconds for the microphone. How many of you have done that in the operating room at any point? How many of you would consider doing something like that in the operating room in the future when you have a moment? Cool, me too. We actually tried some with Dr. Bannon the other day when we were in some long hits. All righty. When thinking about this topic of surgeons and physical activity, I was also interested in whether exercise outside the operating room has an effect on surgeon well-being and performance. While a lot of surgeons participate in exercises and sports anecdotally, there is fairly limited data on the connection between these activities and surgery. And much like on intraoperative interventions, the studies are small. In Italy, a multi-center randomized clinical trial was completed for 141 surgeons, randomized to either no intervention or a preventative program. This study showed multiple health improvements for the surgeons in the preventative program over a period of 6 months. Included implementing ergonomics principles in the OR and specific physical exercises supervised by a physical therapist outside the operating room. They looked at these surgeons at baseline, at 3 months, and at 6 months. And low back pain was shown to be decreased at 6 months in the surgeons who went through the preventative program compared with those who didn't. And analgesic use had decreased by 50% for the surgeons in the preventative group at 6 months as well. Notably, while opioid use, which is the little red bar there, was very small to begin with, it completely disappeared by 3 months and 6 months for those surgeons in the preventative program. There are other wellness metrics that can be seen in surgeons who exercise. There was a large study of 7,000 surgeons where quality of life was assessed with respect to different metrics, including exercise. Of the surgeons that were surveyed, 55% participated in aerobic exercise to the level of the CDC recommendations, and 36% participated in muscle strengthening activities to the level of the CDC recommendations. And the overall and physical quality of life metrics for those surgeons were superior to the ones who did not complete that level of activity. A recent study from March in 2025 assessed the relationship between exercise by looking at step counts and sedentary time to stress at the start of the procedure, which was based on heart rate variability and a calculated cardiac vagal tone. There were 722 surgeries assessed that were performed by 37 surgeons over the course of a year, and higher daily step counts during the week before the surgery was associated with markers of decreased stress at the beginning of the surgery. While these and other studies show the effects of exercise on surgeon wellness, there's a paucity of data on the effects of surgeon exercise and fitness on outcomes directly. Again, these are sort of experimental things that we can think link out to surgical outcomes due to wellness in surgeons, but we don't have real data that proves patient outcome. Is this relevant to OB/GYNs? The short answer is mostly. Intraoperative exercises are obviously not applicable to emergency surgery. And there's also likely a time cutoff for which it makes sense to incorporate these micro breaks and these stretches. For very short procedures, for in-office procedures, and for some procedures with awake patients, this may not be the ideal environment for formalized stretching. However, there are many opportunities to incorporate switch exercises into the gynecology OR. For example, when you're scrubbing from sort of vaginal sterile to abdominal sterile, you can take a moment to do some of these exercises. You could even just take 20 seconds to stretch. And we do rarely wait around in the operating room, but if there's ever a pause to wait for an instrument or something where you're not doing something else, that could be a moment to turn it into a stretch break. In addition to surgeons, incorporating these things in the operating room could also help everyone else in the OR too, including the scrub tech, medical students who are often retracting for long periods of time, residents, anyone who's around really. And so the benefits likely extend beyond surgeons to everyone in the operating room. I also want to be realistic about incorporating another checklist item into the operating room and the reality of everyone, suddenly prioritizing exercise in their already busy life. So it's something to be done in moderation. Given the variety and intensity of surgery that OB/GYNs do, intraoperative stretches and exercises are more of a tool to reach for than necessarily a habit that everyone has to take on all the time. And exercising outside of the operating room is definitely a good thing for surgeons, as exercise has been shown to have so many benefits, but we really could benefit from more data on how it can affect our surgical outcome. The big picture is that exercise interventions inside and outside the operating room may be a way to benefit surgeon physical and mental well-being. Potential benefits range from decreased pain and muscle fatigue to improved stress and precision. A lot of studies look at the theory that if you're improving fatigue, whether it's mental or physical, that leads to wellness and that leads to better focus and that leads to better precision and better surgical outcomes. It's a bit of a stretch, not something that we've seen in the data, but a good theory. A systematic review of systematic reviews on the benefits of physical activity and all-cause mortality and other chronic conditions also concluded that specific threshold-based exercise recommendations, like the CDC guidance of 150 minutes of exercise a week, are not necessary because health benefits are seen when people simply increase their activity in any way. So inside and outside the operating room, adding in any amount of stretching or exercise is likely to be good for you. Thank you.
Great talk. I had a couple questions about, I didn't notice a lot of information about vaginal surgery. That's one of the more difficult areas, I think, to get correct or organized. And there's a second thing for OB/GYNs, you might have some comments about, we tend to not always treat obstetrics like a surgical, particularly vaginal deliveries as a surgical procedure. And if you watch or pay attention to how you do it, most times we're bent over, we're sitting on the side of the bed, we're leaning forward. We have one person at a stool while the assistant is holding over a leg. And I think obstetrics is a place we could improve even more on.
Yeah, completely agree. The data on vaginal surgery is much less than in others. The study that looked at 500 vaginal surgeons, they all happen to be urogynecologists, did assess whether surgeons standing or sitting had any effect. And it mostly showed that the time length of the surgery was what contributed to more musculoskeletal discomfort and all of those things as opposed to a specific position. But the benefits were seen with trying to maintain a normal posture, which, as you said, a lot of times, especially with lifting, is not done. I suspect that the information on teaching being associated with worse physical pain and discomfort also comes from the fact that contorting your body to kind of optimize things for the seated surgeon is uncomfortable. I didn't look at a lot of obstetrics data. There was some information on like obstetricians and gynecologists, but mostly pertaining to their work in the operating room doing gynecologic surgery. So I'm not sure if there are a lot of studies in that area. I'm sure it's ripe with possibilities. There was some information on pregnant surgeons, and it didn't appear that pregnancy changed much. It just changed where the pain was. Lower.
I'll just give a plug for actually doing this in the OR. I do try to do it in my longer cases. And I will say every time I've done it, the entire operating room participates, like the nurses, the techs, the anesthesia team. And it sort of like gives a morale boost to the whole operating room because everyone's like sort of taking a break and having a good time. So just a big plug.
Apparently, the endocrine surgeons all have that app already. And at least one of them routinely does it in every single case. So if you needed more.
Yeah, if they can do it, we can do it.
Yeah.
I also think it was nice to see that there was variability in the amount of time that you could do these things for, and it still seemed to have benefit. So, you know, someone who might say that taking a 5-minute break could interrupt their surgery, or if there's something that takes focus, obviously that takes precedent. But even 20 seconds, I mean, it takes you 20 seconds to get your new gloves. So, Dr. Kelly.
Yeah, the other time that I was thinking, especially from the obstetric side, bouncing off of what Dr. Lick said, is for C-sections when anesthesia is like putting in the spinal and you're like, oh, it's taking so long.
Yeah.
Could do some stretches to
Absolutely.
prep.
Sometimes too, if you're an additional person in the operating room and you're waiting for cord cutting for 60 seconds, if you're not someone who's actively managing bleeding or resuscitating baby, that's 60 seconds of time. So
Yeah, do some neck stretches while they stimulate.
I also think to Dr. Lick's point that we often contort ourselves in the obstetrics room. I've had a couple of nurses, both on the labor and delivery floor and on postpartum, just bring up like, oh, do you want me to do that with the bed higher? I think like other, especially nursing teams are trained to try to modify, or like implement these ergonomics to make it easier for us, where we come in and we sort of see what's going on and just work with that. So I think we can take a little bit more ownership and, you know, not just raising the bed in the operating room, but doing that in a labor and delivery room, even if it's like to place a cook or whatever it is, if that's helpful. So.
Okay, I have another question. So say you were in charge of creating a resident research project about this, what would you do?
So I think one of the biggest things that I saw was it was helpful when studies included all ranges of levels of training. So I think I would try to set up a study that included more experienced surgeons, residents. I do think it's valuable to include other people in the operating room as well. But I think just having maybe a 3-arm study where we looked at people who followed a specific program like this, and then people who followed like breaks, but doing whatever they wanted to do for their own directives, and then looking at people who didn't and seeing if anything changed. Because I do think there's something to be said about letting people do what feels good to them and not just doing like prescribed exercise. So that's what I would do. Sounds hard for a resident research project. Dr. Lett?
I just had one more point to make,
Yeah.
particularly to the residents and medical students as time goes and you progress in your career. You know, I've always been someone who's exercised from, you know, quite a ways back up until now, and make sure that you are always thinking forward about what types of exercise you can do. Because eventually what happens, you know, every decade or so, you find that you can't do the old exercise that you used to be able to do. And the more diversity you have in the exercise, the more likely you are to maintain doing some type of exercise. So keep that in mind. You know, in your 30s, you may be able to run, which I could do. Your 40s, you may be able to bike, which I could do. Your 50s, swimming. So just always keep in mind something. It also helps you with your not getting bored with it and stopping exercising.
Yeah, and I think that goes along with the idea that there's no amount you have to achieve or exact thing you have to do. Really, anything is helpful.
Great talk. Thank you for that. Just curious, were there any studies about like hand size and instruments and like the ergonomics of how smaller hands do with those?
Yeah, so in addition to the different positions, there are some studies that looked at hand size, which typically is surgeons that identify as female have more pain and more injury, using instruments that are kind of a one size fits all size and shape. The Society for Surgical Ergonomics also currently is running a study looking at whether surgeon hand size affects kind of pain and injuries in the operating room. So I don't know how you can get in on the study, but you can check out their website to learn more. There's also some thought that it could be a question of equity because if female surgeons that have more pain, however, that idea that female surgeons have work in the operating room was shown in some studies and not in others, and so it's not a very well established idea.
Along those same lines, you talked about how left-handedness seemed to be protected in one of the studies. We think of like the world being designed for right-handed people. Like, why do you think that was the result that they found?
Yeah, not sure, and they didn't have a good explanation for it either. That was in the vaginal surgery study. And it may just be that they are able to accommodate positions that, you know, if most people are right-handed, then most people want to be in like a certain spot, have good reach to do something. And so maybe being left-handed, you have, you know, better availability with the other spots. I'm not totally sure. Dr. Wilkes, do you have some experience?
As a left-handed vaginal surgeon, because you operate in a right-handed world, like from the very beginning of my training, I've been encouraged to do things right-handed. And so I think that left-handed surgeons are more likely to have increased ambidexterity. And so in that capacity, I think that you're more able to assist on either sides or operate from either side because you're used to having to be a little bit more flexible in the operating room.
That makes a lot of sense. I think we're always told to kind of strive for ambidexterity.
Not database, but just my personal experience.
That was not a trend that was particularly statistically significant either, just an interesting observation, but I do think that it's likely related to